Hello and welcome to the UVA Mini-Med COVID-19 podcast segment on testing for COVID-19. I'm delighted to be joined by Dr. Amy Mathers. Dr. Mathers is a physician who specializes in infectious diseases. She is also the Associate Director of Clinical Microbiology at the University of Virginia and is leading the COVID-19 testing efforts at UVA. Dr. Mathers, thank you for taking time out of your busy schedule to share your expertise about this important subject.
Well, thanks, John. I'm excited to be here.
All right, so let's start with the basics. What tests exist for identifying COVID-19 and how do they work?
Yeah, so probably the test that gets the most press and is probably the most important test for what most people think of when they say, I need a COVID test, is the PCR test. And so that is a molecular diagnostic that picks up the bits of virus that would be in someone's throat or in their nose or their lower respiratory tract. And so I talk about that as a diagnostic test or a viral diagnostic test. And the way that it works is that you take a nasopharyngeal swab, and a lot of the swabs have gotten a lot of news because there's been such shortages, and people are like, what is up with the swab? I mean, why can't you just use a Q-tip? And unfortunately, because it's an RNA virus, RNA tends to be quite delicate, and you want to make sure that when you take a sample from a patient that you get it to the lab so that you can actually make sure that if virus was there in the beginning or when you collected it, it's there by the time you run the test in the lab. And so we like to use these specialized swabs called flocked swabs. And so I've got one here, and you can see they've got like kind of, I don't know if you can see that, but fuzzy little hairs on the end. And so that's kind of a special swab, and that goes straight back in the nose, almost that far back to your ear, out. And I usually recommend doing it on both sides just to prepare somebody. Some people say it's just a kind of uncomfortable tickle. Some people feel like it's almost like a brain biopsy, but it's not. It's usually very temporary. The other thing you can do is, so then you take that and you have to put it into fluid, usually kind of special fluid, and you break the swab off, and then that's what you send off to the lab. And you can also do throat swabs, but also, again, it's important to see the swab's a little bit bigger, but again, flocked, so that you can pick up all the debris in the back of the throat. There are some other tests coming to market that are also viral diagnostic tests, PCR tests, to look for those viral bits and the signature of COVID. And there's been talk of using saliva and sending that off to labs. A lot of those tests haven't completely cleared the FDA, but some of them are. You can see why people would think, well, that'd be great, because then I wouldn't have to go have this stuck up my nose and have a doctor collect it. I could just put saliva in the mail and send it off to a lab, and they could tell me if I had COVID. It's just there's a lot of nuances in how those testing works, how testing like that could work. And so some of that's coming, and hopefully soon, but just so you know, that's been some of the problems with testing, is getting the swabs, getting the viral transport media, and then just having enough of the materials needed to run the test. So to do a PCR, to detect the RNA, you have to first pull the RNA out of the specimen cleanly, or extract it. And that's one step, and you need all sorts of specialized chemicals and equipment to do that. And then you run the PCR, so that amplifies the RNA so that you can actually detect it on a machine. And then you have to give the result back to the patient once you know it's either there or not there. We get a lot of questions about how good these tests are. Well, they're pretty good, especially early on in a symptomatic coronavirus infection. There's quite a bit of viral RNA, and so the tests work fairly well up front early on. And then with some of the other platforms out there, and I can talk more if you have questions about this, there has been noted to be some variability in how well the different machines and instruments and reagents work to detect virus from a sample of a throat swab or a nasopharyngeal swab for the diagnosis of COVID. The tests we're using here at UVA are all quite sensitive, and we run most of our tests are looking at about 100 viral particles per mil. And so that's thought to be quite sensitive, and probably about as sensitive of a test as you'll get. The other kind of test that people are talking about or is making the news is antibody testing. It's a very different thing. And so antibody testing you might want to get to see if you had a COVID infection or had a SARS coronavirus infection. To do antibody testing, you need a specimen, a different specimen. You don't want to get it from your throat. You get it usually from testing someone's blood to see if their blood has mounted antibodies against the SARS-CoV-2 or COVID-19. And actually that prompts me to think of the fact that, coronaviruses, seasonal coronaviruses are circulating or have been circulating in the United States for a long time. And those seasonal coronaviruses usually are, can account for some of the common cold. And so early on, there was a lot of concern that some of the serology was going to be cross-reacting with some of those seasonal coronaviruses. And that hasn't really panned out. That most of the tests that are cleared through FDA, and there's about 10 platforms at this point that will do antibody testing accurately, are actually working fairly well to detect people that actually had a SARS-CoV-2 infection or COVID-19. What we're finding is that the tests are quite accurate for COVID-19, the ones that are on the market with FDA. However, when you're testing in a situation where there's very few people who have actually had the infection, even a small number of false positives can really add up. For example, if you only have a population like we think in maybe Charlottesville, where probably only about 1 to 2% of the population have actually seen the virus or been infected or had an opportunity to mount coronavirus antibodies, and you test it on 1,000 people, and out of those 1,000, a lot of the platforms are only showing, 4 false positives out of 1,000, which sounds pretty good. That's like less than a 1% false positive rate. But the problem is if it's only 2% of the people that have actually had it, you're going to have the number of false positives that you have out of the positives that you got back from the test is actually quite high. And so we're really reluctant to just start doing massive amounts of serology on lots of people. The other real big concern about serology is we don't know what it means. So we do not know if detecting COVID-19 antibodies in somebody's serum means that they are protected from getting a subsequent infection. And I think we'll be learning more about that in the coming months, but for right now, we really don't know what it means. And I think people see the serology or the antibody testing as, great, I'll get an immunity passport, I'll put a sticker on my shirt that says I'm A-OK for not getting a coronavirus infection, but we're just not quite there yet. And it's important to note that unlike a lot of clinical tests that come to market, because there was such a desperate need to get serology to market for clinical testing, the FDA did not require any clinical data. And so we don't really know how well these tests perform in terms of they show that somebody is immune from getting a subsequent infection. And we don't even know if the antibodies that they test for kill a virus in a test tube, which is a pretty standard thing, but there was just a lot of rush to get to market. What we do know is they work pretty well in a high prevalence population to say who had coronavirus and who didn't, at least the FDA cleared ones.
Yeah, that's an interesting point. You mentioned sort of if there's 1 or 2% of the population that has the virus, even if the test is really good and there are very few false positives, like you used the example of 1,000 people, if 1% of the population has it, that's 10 out of 1,000, right. But only 5 people, they test positive, but they don't actually have it. That's right. That's close to how many people actually had it. That's remarkable, yeah.
Yeah, so that's one of the problems with doing large serology testing on a naive population.
Okay, yeah, thank you for sharing all of that. So your lab has been in the news for developing a new test for COVID-19, and the lab now processes the results of the COVID-19 tests for both the UVA Health system and hospitals across the state. Can you please share with us what that process was like and what is different about the new test?
Yeah, like you've probably heard from other mini med school segments, there's been a lot of themes with coronavirus. One of them is one of shortages. And what I would say is that when coronavirus first started emerging, or we first sort of knew we were going to need a test, we normally would think about developing our own test. However, there was additional regulation put in place by the FDA that said if you're going to run your own test, you have to clear it with the FDA. And normally when we as a clinical lab run our own test or develop our own test, we do our own internal controls and make sure that we add a lot of additional controls to make sure that the test that we're doing we know is accurate and working well. Well, I think the FDA was maybe concerned that people were going to be developing tests that didn't work very well or something. And so they put in this additional requirement, and we got fairly scared off by having to file with the FDA because that's usually a huge amount of work that a diagnostic company would put together that packet. And so we really wanted to use the CDC's assay because that was FDA cleared. So if you used the CDC's assay and you could get all the components of that assay into your lab and followed their exact recipe, then you didn't have to file with the FDA. But the problem is every single person in the country was trying to do the exact same thing at the exact same time. So you couldn't get the machines to run the PCR according to the CDC recipe. You couldn't get the reagents or the chemicals that you need to run the CDC assay, and you couldn't get the virus or viral particles as a positive control to show that if you spiked a sample, your assay worked, which is just critical to any lab medicine. And so what we did that was sort of unique, the UVA method, it wasn't really that we developed a new method, it was just that we were good at pushing the FDA to modify what would count under the CDC assay using slightly different ingredients and slightly different machines. And so that was really what we did to develop the UVA assay. It then allowed other people to also follow, because then the FDA amended what you could do and broadened it. So it allowed other labs to do the same and try to get some of those reagents that were a little easier to come by. Through that, we had generous researchers who donated equipment to run those assays from the School of Medicine. And Melissa Kendall and Jim Casanova and Chris Musculloch all donated equipment, some of which we're still using. That assay is quite laborious and takes a lot of time, and we can only run 23 samples at a time. And so we knew we needed a better commercial method with a lot higher throughput, and that's usually what you do in a clinical lab, is you use platforms that are kind of sample in, answer out with a lot of parts in the middle. Basically, as soon as we got the CDC assay, within 3 or 4 days, we were up and running with a commercial platform. And that has the ability to do 96 at a time. And we have 3 of those machines. So if we run those back to back and we keep everything running, we can run about 600 a day. We then also got a third instrument in that can run the test very, very quickly and on demand. So that second assay is, you have to fill up a plate of 96, you put it in, and then it runs, and you get the results of 96 about 8 hours later. The best thing, though, and the thing that everybody would love is, sample in, answer out in an hour. And so that we do have some of that now online, but again, there's been lots and lots of people in the United States want that. So there's been a lot of issues around getting allocation, getting enough of those supplies to run that test for everybody. So we have to really limit who we run the rapid test on. And so that's actually what I spend a lot of my time doing, trying to figure out how to prioritize everybody that needs testing and kind of on what timeline.
Could you please tell us a little bit about what that looks like, the prioritization of certain individuals over others?
Yeah. And you had asked also about, and how do we prioritize and how do we think about this? So University of Virginia, we're used to testing patients that come to University of Virginia. We're not really used to doing a large, what people refer to as a reference lab. And so you'd mentioned, testing for other hospitals or testing for the state. Well, because we were able to get all this capacity, and because Mindy Poulter, who really led a lot of the charge and is very, very good at developing molecular diagnostics and bringing in molecular diagnostics of all kinds, that's really what got us to ramp up our capacity. And as soon as we had capacity, we started testing for other hospitals. Because the problem is when you've got an inpatient who you're suspecting of coronavirus, you need to keep them on isolation until you can say, I tested them and their symptoms or their fever or their cough is not because of coronavirus. And so the quicker you can do that, the less of the sort of protective personal equipment, the mask, well, we all wear masks now, but the gowns and the gloves and the face shields and everything that you need to care for somebody who has coronavirus in the hospital safely. We were using up a lot of PPE waiting for tests to come back. And so we use those rapid tests on that group of patients. As soon as we got testing at UVA, we started offering it to other hospitals so they wouldn't keep burning through PPE, because we knew they were also facing the same demands. And then because we've got these large instruments that can do 600 a day, or total 96 at a time on multiple runs, we wanted to share that capacity with the public health lab or with the Virginia Department of Health. And so we are doing point prevalences at nursing homes around the state, community testing events around the state, or supporting testing for community testing events around the state, as well as testing for the Department of Corrections. And so trying to fill up our testing platforms every day so that we can get as many people that need tests tested in the state of Virginia.
Wow.
And then, like I said, we try to prioritize the inpatients first because you need those rapid results. And then it kind of falls from there. Symptomatic folks, sometimes employees get prioritized because we need to get them back to work, or somebody who maybe is symptomatic, but it's tough to say, and they need to go emergently to the operating room, and you would change the way that you did the surgery if you knew they had coronavirus. So those are some of the people that we put on the rapid test. And then we try to get other hospitals testing done quickly and along with everybody else's.
Okay, would you mind, and I don't know that, just as an aside, I don't know how complex this is, so it's okay if it's like, oh, it's too much. I'm curious about, it seems like when the tests were first coming out, it took several days to get the results from those tests. And then you mentioned, the tests you have take about 1 day, but you also have some that take an hour or around then. How is that possible? How are you able to get the results back in an hour versus, several days?
Yeah. So, how can some tests be so fast and some tests take so long? So when we first started, we were not able to do, before we had testing at University of Virginia, and it's important for people to recognize this, a lot of the testing was going to commercial reference labs. And I used that word before, that UVA is not really a reference lab. And a reference lab is a lab that's set up to do testing for kind of everyone, a clinic or whoever wants to send blood there to get tested for X, Y, or Z. And some of the most common, well-known ones are places like LabCorp or Quest. And so I think early on, the federal government saw a strategy of, let's make sure that Quest and LabCorp have lots and lots of reagents and can run massive amounts of tests because they're set up to do that kind of throughput. The problem is when it first came on, LabCorp, there's only one of them for the whole East Coast. So what was happening was us and everybody else was sending all of their COVID testing to LabCorp. And so even though their tests take, say, 6 hours to actually run, it was taking sometimes 11 days was the maximum, but many, many days just to get through the queue or the line of how many tests were in front of it because they were getting so flooded. And, you know, the commercial labs have expanded capacity way beyond what we will do. I mean, they're doing 20,000 tests a day, but again, they're serving a huge area. Now LabCorp is working with CVS, and so just really different volumes. So that's one way that testing turnaround times can get really long. If you can't manage the number of specimens coming in, you end up with a line, and we all know what it's like to stand in line. You can be standing in line till you get on the assay to say COVID, yes, no, for sometimes days. And so we do not want that to happen at UVA. So we will say no to testing if we think it's going to push us over into another day. So so again, a lot of what I'm doing is just trying to police. If the Department of Corrections says, Amy, can you run 1,000 tests for us? I will say, not in a day, I can't. It will take me 2 days to get through that, plus all our other work. So that's one reason some of them take so long. The 45-minute test is actually a slightly different technology. It's proprietary, it's under Cepheid, but it's not a PCR per se, I don't think, but it's a nucleic acid detection system. And so ultimately, once you start getting into PCRs, you're usually over an hour that it takes it. And that's just, PCR is just you start with a few pieces of DNA and then you logarithmically multiply them until there's enough of them to be detectable. And that's kind of a tried and true technology that works really well for molecular detection of nucleic acids of all kinds. Because you use the COVID signature to find. Some of the other diagnostics are using different technologies, like there's a CRISPR-Cas that's discussed, or some of these novel ways to how can we detect that exact coronavirus RNA signature without having to spend the time amplifying it. Some of those, like the Abbott ID Now, the bread box kind of thing, that people are really excited about, heard it was a 13-minute test. Unfortunately, it doesn't use PCR, but it's not proven to be very sensitive. And so the FDA, even though they approved it, have since come out with a warning saying, be real careful, and if you use it and you get a negative result, you probably need to back it up with a more sensitive platform. And so for us, back to Charlottesville or back to the state of Virginia, we don't have enough positives. We're not like New York City in the peak where that would have a utility. For us, most of our tests thankfully come back negative. And so if we had to do 2 tests on that, like we had to do a first test that was 13 minutes and that came back negative, and then we had to do another test, it would just be a waste of effort. So we use mostly PCR platforms, but the Cepheid test does use a different technology and is quite rapid at 45 minutes.
Okay. Thank you. I wonder, you've used the word sensitivity a few times, and I'm wondering if you can just maybe explain to us what exactly does sensitive mean? Yeah.
So when we talk about testing, and I've apologized to the audience for sensitive, we talk about sensitive and specific. And so sensitive is if the disease is there, how good is the test at detecting it? And so that means if it's negative, are you confident that there truly was not disease there? That is a sensitive test. Specificity talks about if the test is positive, did the person actually have the infection? With COVID-19, we haven't talked too much about specificity issues, because if you're detecting viral RNA there, you probably had the infection recently or have the infection actively. So we don't worry too much about specificity. I can get into that onto the tail end because people actually shed virus or shed the viral RNA for a really long time, even past symptoms. So it does get into like a positive doesn't necessarily mean you're still infectious. It doesn't still mean that you're going to get sicker with COVID or something like that. But for the most part, the specificity, if you get a positive test, it's probably because you had viral RNA in your airway. A negative test, and how sensitive is the assay? Again, if we talk about just the testing platform in the lab, pretty sensitive. But that's not what usually people are asking me about. They're saying, if I have a fever and I get a COVID test and it comes back negative, am I confident that it's not COVID? Early on in China, we were seeing there were a lot of reports showing that some of the tests were not the most sensitive. We now recognize that that was probably some of the testing platforms were missing some of the tests, and we think that the tests that are available in the United States are much more sensitive. And also, it really depends on where you're at in the infection. We know that when coronavirus first starts replicating in your nose and your mouth and throat, there is a lot of virus. So from the time of the first symptom, basically 5 days after that, there's hardly any false negatives. I will say that if you just like touch the tip of your nose with this thing and you didn't actually get in there, that's another way that the test can fail. But if you get a well-collected specimen and it is negative, you do not have coronavirus. We quote a 97.5% sensitivity. Problem is if you had a fever and a cough and you're later in the infection, we know that the virus starts falling off. The amount of viral particles and the amount of viral RNA starts falling off after 5 days. And what we know of coronavirus is that some people have all those symptoms up front and don't feel too bad, feel bad like they have, the flu or really don't feel well. But it's actually, they don't really start having the complications of coronavirus that bring them to the hospital until 7 or 10 days. And that's when they're starting to have some, what we're finding out is maybe some issues with clotting and some of the complications of coronavirus. The test is not 100% or even 97.5% sensitive there. And so you have to use a bit of common sense and a bit of clinical judgment about, boy, that looks a lot like coronavirus. This patient was exposed to somebody with coronavirus. They have hypoxia. They have what looks like the right chest x-ray finding hypoxia, meaning oxygen, not enough oxygen in their blood, all things that are very consistent with coronavirus and the right time frame. If their test comes back negative, I don't believe it. We put them into isolation as though they had coronavirus, and then sometimes we'll get a lower respiratory specimen. And if that comes back negative, it's probably not coronavirus. So the tests do work fairly well, and there's been a lot of misinformation about how well the test works. Part of it's complicated for all the reasons I said to you. There's different platforms available. Some of the tests aren't actually as good as the others. And it depends on where you're at in your coronavirus infection. So the one thing that I'll say about sensitivity and a place where we do not know, again, that word sensitivity, how well the test detects is in people that do not have symptoms. We are only just beginning to understand coronavirus in people that don't have symptoms. And so we need to be really careful when we start getting into the asymptomatic testing. So somebody got exposed to somebody else with coronavirus. A lot of things can happen, and I'll just go ahead and go through quickly a few scenarios of what can happen. I get exposed to coronavirus. John coughed all over me. Nobody was wearing a mask. I get exposed to coronavirus. 2 to 3 days after that, if the virus begins to replicate in my nose, anytime before that 2 to 3 day window, you're not going to detect coronavirus. It has to start adhering to the receptors, the ACE receptors in your airway, and then start replicating before it can become detectable by any test. That also is, it's probably not contagious in that time frame. You just didn't have enough viral replication. So, but the problem with coronavirus is, let's say I start having viral replication at day 3. I may not, unfortunately, start developing symptoms until day 5. And so I'm technically shedding virus all over the place, and I don't have any symptoms. For somebody probably about my age, likelihood is if I get coronavirus from John, I'm going to get symptoms. And so once you start developing symptoms, like I said, about 5 days after the onset of symptoms, we know that people shed lots and lots of virus. And so it's detectable by any test. So now we've got a situation where you were negative right after exposure because you didn't have enough virus to even be detected or contagious. You start making virus at day, say 3, these are your averages, and it's detectable, but I still haven't gotten symptoms. And that's the reason why everybody should be wearing a mask, is so that they're not spreading it during that time before they have symptoms. Once people get symptoms, mostly they'll start self-isolating. And that's the problem with coronavirus, is people don't know they have it. And then I'll shed virus and I'll have my whole COVID infection. The other group of people is people that I could be one of those lucky ones that gets exposed. John gave me coronavirus and I actually have it, and it did start replicating, but I never got symptoms. What's going on there? What we're starting to understand is those people don't develop nearly the viral loads, and they're probably not nearly as contagious. The problem is in that 2 days before I develop symptoms versus me being asymptomatic the whole time, you can't tell the difference between what I'm going to be, because we don't have a crystal ball. But our contagious rate is completely different, whether or not you never develop symptoms, probably not shedding lots and lots of virus, versus I was in that window before I got symptoms. I do then shed a lot of virus. And so I just wanted to point out that, especially for that asymptomatic stays asymptomatic, we really don't know what the sensitivity is. We are just starting to learn how long those patients will carry virus. We know that it's lower than people that actually do develop symptoms, so they're probably less contagious. We also know that from modeling and from some of the outbreak work, that people that didn't have symptoms didn't shed nearly as much or cause as many subsequent coronavirus infections in other people. So I think it's really important when we start talking about testing all these people that we think might have coronavirus, we want to test everybody. We got to really think about the fact that we don't know what we're doing when it comes to asymptomatic testing, and when to test or who to test and how to do that. So.
Oh, that's really helpful. It puts things in perspective. If someone coughs on me and they have the, COVID, what are the possible pathways and what does that look like? That's really helpful. Yep. Thank you. Thank you so much, Dr. Mathers, for teaching us all about testing for COVID-19. Your dedication in leading the charge against this pandemic is really inspiring for me to see as a budding clinician, and I'm grateful for you and your team's efforts. Thank you also to those of you at home listening and doing your part in mitigating the pandemic. For those of you who want to learn more about COVID-19 testing and efforts at UVA, please see the links in the description section of this video. Please also feel free to submit any questions you have in the comments section. Thank you for listening.